Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is malignant otitis externa. So in this presentation we will briefly discuss the anatomy, then introduction, microbiology, the pathogenesis of the disease, diagnosis, investigations and treatment. So brief anatomy is the ear. It consists of three parts: the external ear, middle ear and the inner ear. So this disease is basically confined or start in the external ear and then spread beyond the premises of the external ear. So external ear, it composed of the pinna, the external auditory canal and the outer surface of the tympanic membrane. So this external auditory canal, it consists of a cartilaginous part and the bony. Medial two-third is bony and outer one-third is cartilaginous, and it usually affects at the osteocartilaginous junction, and it is also connected through fissures of Santorini to the parotid area, so disease can spread there. It can also spread medially, superiorly, inferiorly, and externally to involve the pinna as well. So this is how anteriorly there, if you see, this is the tympanomandibular joint area of parotid. This whole area, it becomes swollen, and if involved the pinna, it can also get swollen as well. So in this picture, if you see this external auditory canal, it is completely swollen. The tragus is swollen. So this infection, it spread to involve all these areas. Introduction: it is an invasive infection and a progressive one. So invasive infection of the soft tissue of external ear or the external auditory canal and its surrounding structure, and it is a bacterial infection. It is quickly spreading to involve the periosteum and bone of the skull base and the temporal bone. It is aggressive and potentially life-threatening disease. So aggressive treatment and urgent diagnosis is mandatory for proper resolution of the disease. It is also known as, because the name is malignant otitis externa, but it is not a malignancy, but due to its progressive nature and high morbidity, the name is given. But its main name is necrotizing otitis externa, or since it is a skull base infection, so also known as skull base osteomyelitis. The microbiology, 95% it is caused by Pseudomonas aeruginosa, and all other cases non-pseudomonal, the most common non-pseudomonal isolation. Staphylococcus aureus is the most common. Recent studies shows a rising trend of both MSSA, methicillin sensitive, and methicillin resistant Staph aureus. Rarely the other gram-negative bacterial species, they include Proteus, Klebsiella and Acinetobacter, and in some cases fungus is also cultured, and the common one are the Aspergillus and the Candida. The predisposing factors include, it is mainly seen in the diabetic patients and also in those patients who have any immunocompromised state, or they have weakened immune system, or have immune diseases or the diseases which make the immune system weak, like HIV, malignancy, then chemotherapy, patients on chemotherapy, and advanced age also, because immune system is weakened in these conditions. Pathophysiology: this infection, it basically starts as a diffuse otitis externa, localized or diffuse otitis externa, and then it progresses to the cellulitis and chondritis, and ultimately extending to the skull base. It potentially involves the stylomastoid foramen and affecting the facial nerve, and the jugular foramen to involve the glossopharyngeal vagus and the accessory nerves. Then when also extend to the temporal bone, resulting in petrositis and leading to osteomyelitis. Necrotizing otitis externa can result in serious complications, including the development of cranial neuropathies, brain abscess, meningitis, and dural venous thrombosis after intracranial extension. So, in short, it starts as a cellulitis and spread to become chondritis and then lead to development of petrositis, osteitis, and ultimately lead to osteomyelitis. And osteomyelitis is a very aggressive and dangerous or fatal condition, usually in this area of the skull base and the temporal region. The spread of infection, there are different patterns of spread of the necrotizing otitis externa. Anteriorly, as already mentioned, there is connection through fissures of Santorini to the parotid gland and the temporomandibular joint area, and thus affecting the muscles of mastication. Medially, it spread to the skull base, affecting the temporal bone and petrous apex, jugular foramen, and involving the paralysis of the 9th, 10th, and 11th cranial nerves, carotid canal, and clivus. Posteriorly, it may extend to the mastoid process and the venous sinuses. And inferiorly, it affects the stylomastoid foramen, leading to paralysis or paresis of the 7th cranial nerve, the facial nerve. Intracranially, it often occur. The intracranial extension often occur once the infection has successfully eroded the temporal bone or extended through the existing skull base pathways. Intracranial spread is suggested when there is dural enhancement within the intracranial compartment. It may indicate the involvement of the sigmoid sinus, jugular vein, internal carotid artery, jugular fossa, cavernous sinus, meninges, and the dura. Okay, so for the symptoms, uh, earache is the most common symptom, but it will be very severe or excruciating. It will be persistent and worse at night, even unbearable in some patients. So this is the most common or pathognomic symptom for malignant otitis externa. There may be ear discharge present or the otoria. There will be swelling of the outer part like tragus, pinna, or interiorly into the external auditory canal. Patient may also complain of heaviness in the ear, oral blockage, and pain on chewing. Then patients may also have fever, headache, dysphagia, facial weakness. These symptoms are basically showing that the disease has progressed and involved the cranial nerves or causing complications. The signs or the examination findings: on examination, the external canal, especially the tragus, pinna, pre uh, auricular area, they may be swollen. There will be tenderness on pulling and pressing the pinna and the tragus. Otoscopy shows swollen external canal. Discharge may or may not be present, or the granulations may be present, which is a very important finding for the diagnosis of the malignant otitis externa. And these granulations or the swelling, it is usually present at the osteocartilaginous junction. Facial nerve examination may be normal. There may be weakness or paresis or paralysis. Other cranial nerves should be examined, and they may be involved. Like the common one are the glossopharyngeal, apart from facial glossopharyngeal, vagus, and the accessory nerve. However, the 12th nerve and the other nerves, they are rarely involved. So this is the picture for the malignant otitis externa. The tragus is swollen, external aortic canal is very much narrowed, and the discharge is present. Here the discharge is present, but in this picture the infection has spread into the pinna, causing its swelling as well. So otoscopic examination, as already mentioned, the hallmark finding is the granulation tissue on the floor of the ear. So this is the granulation tissue and at the junction of bone and cartilage. This is the tympanic membrane which looks intact, but this external aortic canal is swollen, narrowed, and swelling or boil or mass or granulation at the osteocartilaginous junction. Here again, this is the granulation tissue, but this is mild discharge, and behind it looks okay. Investigations. The diagnosis slide I will discuss after the investigations. So certain investigations or a whole list of investigations are here which help us to diagnose malignant otitis externa. Complete blood count may show neutrophilia. ESR and CRP, these are the inflammatory markers. Blood sugar level, as it is mainly seen in the diabetics. Ear swab is taken for culture and sensitivity to know the infective organisms and the antibiotics which are effective against them. CT scan, MRI, technetium bone scan, gallium 67 scintigraphy, and biopsy of the granulations. Erythrocyte count, ESR, erythrocyte sedimation rate, ESR, and C-reactive proteins. These are the inflammatory markers which are typically elevated in these patients, and the ESR is usually above 50 and CRP is above 25. If both of these they are high, so suspicion of malignant otitis externa with the symptoms already described is made, and these tests can be utilized to monitor the response to the antimicrobial therapy and help assess the disease progression. If they are with the medication, these both markers they are going down, it means that the patient is responding. MRI is best for detecting the head and neck soft tissue changes, intracranial extension, while CT scan is ideal for identifying the bony erosion. However, technetium-99 scanning is the most sensitive imaging modality for necrotizing otitis externa and identifies early bony disease. So this is the excellent test for initial diagnosis. However, it remains positive. Once it becomes positive, it remains positive. So we cannot monitor the disease progress with technetium-99. For that, gallium 67 scintigraphy. It is a highly sensitive test to check for the resolution of malignant otitis externa. It detects early changes of the bony involvement and helpful to monitor for disease resolution. This is for diagnosis, and gallium 67 is for monitoring the disease resolution. Biopsy of the granulations, if present, is carried out, which distinguish it from the squamous cell carcinoma. So for diagnosis, mainly it is clinical. An elderly diabetic with earache, severe earache and discharge plus minus involvement of facial nerve, it is diagnostic for malignant otitis externa. And if on culture and sensitivity the organism is Pseudomonas, the diagnosis increases. The specificity and what our suspicion increases for the confirmation of diagnosis of NOE. Then, if it is supported by a positive bone scan, then again it is showing that our diagnosis which we made is more favoring NOE. ESR, CRP, and again if biopsy granulations present, they will confirm that it is malignant otitis externa. Presence of micro abscesses and bony sequestrum if surgery is performed. Technetium-99 is used for initial diagnosis while gallium-67 is used to monitor resolution. So this is the chart or list for diagnosing the malignant otitis externa, the supporting evidence provided by these tests. So, as already mentioned, an elderly diabetic patient with painful ear discharge and facial nerve palsy with no response to treatment and decreased uptake on technetium scan, these are highly suggestive of malignant otitis externa. Now the treatment overview. Treatment is multimodal. It can include both medical and surgical treatment, though role of surgery is now very much limited. Systemic and local antimicrobial therapy, but the therapy is prolonged and may need it for 6 to 8 weeks. Side by side, meticulous glucose control or any other immunocompromised status, it has to be treated or cured or controlled that status. Oral hygiene. Surgery is considered when non-surgical treatments have proven ineffective and is limited to local debridement. If abscesses are present, their drainage and removal of dead bony sequestrum or the dead bone tissue, necrosed bone or bony sequestrum which is there, it should be removed. So, the medical treatment, the first and foremost is the oral toileting, which includes cleaning of the ear with of the discharge with suction and cleaning. But remember that if handling the ear or touching the ear is very painful, then we may have to do it in stepwise fashion, side by side with medical treatment. And once little swelling in reduced, then we have to continue performing this oral toilet. Uh, then systemic antibiotics, because the most common as the infective organism Pseudomonas, so the most common drug affected against Pseudomonas is ciprofloxacin. The oral fluoroquinolones, which is the ciprofloxacin's drug of choice, it is usually given for around 4 to 6 weeks. If there is early infection, but in advanced stages, the patient needs to be hospitalized so that parenteral antibiotics should be given. Again, Cipro 400 milligram IV every 12 hours and till the result of culture report is available. If it is sensitive, then we will continue with Cipro. But if Cipro become resistant, then according to the report, we change the antibiotic. Topical antibiotic drops, they can be prescribed with or without steroids, namely the ofloxacin, tobramycin alone or tobramycin with dexamethasone, ciprofloxacin alone or ciprofloxacin with dexa. But since we are giving the systemic medication of ciprofloxacin, then it is best to change the topical medication. And you can even give polymyxin B, neomycin, hydrocortisone combination. For analgesia, strong analgesic is needed. Simple Panadol, it will not relieve the pain of malignant otitis externa. So either naproxen or flurbiprofen or even addition of opioids has to be carried out. Anti-inflammatory medication, seropeptidase enzymes by the name of Denzen DS, we can also prescribe that. If the external aortic canal is too much swollen, the topical drops will not go, so we have to place the medicated wick. We have to place these wicks inside the ear, and the drops should be instilled over those wick. And that wick, either you have to change the wick daily or let it remain there for 2-3 days. Continue putting the medication. If the patient is in OPD, then recall the patient after 2 to 3 days, remove the wig, check the status of external aortic canal, whether he needs further wig placement or only topical medication. Strict diabetes control is very important. So if the patient's diabetes is not controlled, then consult the diabetologist or a medical specialist so that proper medication should be taken for the diabetes. And patient education is very important. The first is the proper administration of the drops. Keep the ear dry and avoid any water entry. Take a cotton, dip it in oil, or apply Vaseline on the cotton, and then put the cotton while taking bath. And avoid scratching the ear with anything or putting anything inside the ear. So these are important. So these are the important points which patient has to take care. So this is how we made a wick from the gauze piece. Then this wick is dipped in a medicine. Either it is this brown material, it is 10% ichthamol glycerin, which has hygroscopic function and it reduces the swelling quickly. Or if you don't have this, you can instill the topical drops which I have mentioned on it, or apply the cream, antibiotic steroid combination cream like Fusidin H, Flogocid, these creams. You can dip the wick in this medication, then hold. Best is the crocodile forceps, which is an ENT instrument. But if that is not available, simple non-tooth forceps with you hold the wick and insert in the external auditory canal. So this whole wick, it goes inside the canal and only this portion is outside. And you continue putting the drops, topical drops, on this dressing. Patient should lie down with this side above, I mean the affected ear facing upward, and instill the drops and remain in this position for at least 5 minutes, 3 to 4 times a day. And the wick should remain there for 3 days, 2 to 3 days. Or as I already mentioned, our patient has to come daily to change the wick. So both things, they are okay. Surgical treatment, it is reserved for patients whose medical therapy has failed. It includes local debridement, removal of bony sequestra, or abscess is present should be drained. Although surgery has not been shown to improve the outcomes, but it is generally utilized in patients with more severe disease. So this is all about malignant otitis externa. Though rare, but it's a very important topic and can be asked in Viva, MCQs, and OSCE. And one should know about this condition. Thank you.